recently there has been a buzz, and we'll explore that. And may I call upon Dr. S.P. Sinha and Dr. Madhusree Sengupta to kindly chair the session. And Dr. Kollan Gangopadhyay will be speaking on obesity and its endocrine management. I will juxtapose a few lines on the physiatric management, and then Dr. Prosenjit Bhattacharya shall be speaking on the surgical management options in obesity.
বলবেন যে হ্যাঁ আমি ইকুয়ালেন্ট টু ফার্মাকোথেরাপি। ওরা যদি না পারেন 30 বছরে পারেননি, এখন যদি আপনি 3 মাসে করে নেন তাহলে দেন ফাইন, আপনার কোনো ওষুধ লাগবে না। নাও দি ড্রাগস, সো আই নিড টু tell you about the drugs. I'll just quickly go through. So one is the orlistat, which used to be the only drug available. And ditei kharap lagto, because it is not that effective. It's only 2 to 3 kilograms of body weight, to be honest. And it is actually not a absolutely innocuous drug. Because kidney stone chance bere jay. It is contraindicated in patients with renal calculi. And not many people know that. Ar etate etu diarrhea tendency thake. A medicine is not cheap either. So etai amader kache chilo. Ajkal we don't use it that much at all because we have got better drugs. Now I will just quickly go through, and my apologies to those of you who already know it. I'm sure many of you know it, but আমি এটা রিভাইজ করতে চাই because this is the new group of drug which has come up. এগুলো কিভাবে, জিনিসটা কি, ইনক্রিটিং জিনিসটা কি, that I will tell you. So what happened is পেশেন্টদেরকে দেখা গেল যে আমি যদি গ্লুকোজ ওরালি দিই একটা লোককে, তার ইনসুলিন লেভেল এতটা বেড়ে যাচ্ছে। গ্লুকোজ ওরালি দিলাম, তাহলে ব্লাডের মধ্যে গ্লুকোজ গেল, ইনসুলিন সিক্রেশন বেড়ে গেল, এইখানে বেড়ে গেল, সুগারটাকে নামিয়ে দিল। এক্স্যাক্টলি সেম অ্যামাউন্ট অফ গ্লুকোজ আই ডোন্ট গিভ ইট ওরালি, আমি ইন্ট্রাভেনাসলি দিলাম, তো দেখা গেল ইনসুলিন লেভেল এইটুকুনি মাত্র উঠছে। তো পুরো ভালো দে মাস্ট বি এ মিস্টেক, এটি কী করে হয়? আমি ইন্ট্রাভেনাস গ্লুকোজ দিলাম, তো ইনসুলিন লেভেল তো একটু কম, ওটাতে বেশি, রিপিট, কিছুতেই না, অলওয়েজ ইট ইজ দ্য সেম। সো দেন গেট দ্য কনসেপ্ট অফ এই জায়গাটা, এই গ্যাপটা ইজ কল দি ইনক্রিটিন ইফেক্ট। মুখে খেলে পরে কিছু একটা হয় বডিতে, যে কারণে ইনসুলিন সিক্রেশন বেড়ে যায়, যাতে ইন্ট্রাভেনাস দিলে, গ্লুকোজ দিলে হবে না। সো দিস ইজ বিকজ there are two hormones, there are multiple, two main hormones. Moment your food enters your mouth, this one is called GIP and one is GLP-1. এই দুটো হরমোন এখান থেকে তৈরি হয়, one from jejunum GIP and from distal ileum GLP-1. Mind you, the food doesn't have to travel here, এখানে আস্তে আস্তেই এগুলো স্টিমুলেট হয়ে যায়। And খাবার পরে যে ইনসুলিন সিক্রেশন, only a third is because of the sugar that you are taking. Baki 2/3 is because of this too. That is why intravenous dile hocche na, intravenous dile ei hormone gulo berochche na, ei insulin level বাড়ছে না। So then সবাই ওটাতে ইন্টারেস্ট জেগে গেল যে GLP-1 তাহলে তো আমাদের দেওয়া উচিত, দেখা যাক ডায়াবেটিসে কী হয়। দিয়ে দেখা গেল হ্যাঁ ব্লাড সুগার খুব ভালো কমছে, কিন্তু দেখা গেল তার সাথে সাথে ওয়েটও ভালো কমছে। সো এই GIPটা, এটা হলো গিয়ে GLP-1। তো ওটার এফিকেসিটা কেন? এক হলো একটু গ্যাস্ট্রিক এমটিংটা কমে দেয়, পেশেন্টস ডু টেক ইট, তাহলে পেটটা বেশ ভার লাগছে। অ্যান্ড দেয়ার ইজ ইমপ্রুভমেন্ট ইন স্যাটাইটি, কনসিকুয়েন্টলি রিডাকশন ইন ফুড ইনটেক। About 30% of patients have nausea, which with time it does get better. আর এই যে গ্যাস্ট্রিক এমটিং, এদের ট্যাকিফাইল্যাক্সিস হয়, with time that also gets better. সো এইটার ক্লাসিক্যালি পেশেন্টসগুলো বলে যে আগে দেখুন, আমি যদি 4টে মাংস পিস নিয়ে খাই আর আমাকে যদি বেত নিয়ে দাঁড়িয়ে থাকে, বলে না দুটোর বেশি খেতে পারবেন না, আমি দুটো খেলাম, পেটটা ভরলো না, ডিপ্রেসড হয়ে যায়। লট অফ অ্যান্টি ওবেসিটি ড্রাগস ইন দ্য পাস্ট হ্যাভ বিন স্টপ বিকজ দে কজ ডিপ্রেশন। বেরিয়াট্রিক সার্জারি পরেও এই জিনিসটা আছে কিছুটা, মানে ডিপ্রেশনের মতো চলে এলো, যে আমি খেতে পারলাম না পুরোটা, খাওয়ার ইচ্ছে ছিল। বাট দিস ড্রাগস what they do is they increase the satiety and reduce your food intake, therefore তো 4টে পিস মাংস না খেয়ে 2টো পিস খেয়ে আমি খেয়ে নিয়েছি, মনে হচ্ছে 4টে পিসই খেয়েছি, I am not depressed anymore. So this is how they work. The GIP works again, it also reduces the food intake, but the GIP একটু nausea কমায়, so it reduces the nausea, এটাও বডি ওয়েট কমাচ্ছে, so এটাও কমাচ্ছে, এটাও কমাচ্ছে। তো তো এখন অ্যাভেলেবল ড্রাগস কী আছে? GLP-1 আছে, GIP আর GLP-1 এর কম্বিনেশন আছে, and I'll tell you there is one more, গ্লুকাগন। আরে গ্লুকাগন তো সুগার বাড়ায়, একে আবার কী করে আপনি ড্রাগের মধ্যে ঢোকাচ্ছেন? গ্লুকাগনের কিছু ক্যারেক্টারিস্টিক আছে, আই লাভ দিস বিকজ আমার বক্তব্য যা খুশি খাবো, যদি পুড়িয়ে দিতে পারি তাহলে আমার খাওয়াটা হলো আর ওটা গায়ে লাগলোও না। সো গ্লুকাগন increases your energy expenditure. None of these don't increase the energy expenditure. Glucagon does. So the third molecule which is coming in the pipeline is a combination of GLP-1, GIP and glucagon. এই গ্লুকাগন ব্লাড লেভেল বাড়াতে গেলে ওই সুগারের উপর এফেক্টটা এইটা ব্লান্ট করে দেবে, সো হাইপারগ্লাইসিমিয়া করতে দেবে না, বাট ইটস ওয়েট রিডিউসিং এবিলিটি ইজ মেনটেন্ড। So if you look at GLP-1 receptor agonist only, which is available in the market right now and licensed for treatment of obesity, so we have got semaglutide. You get oral semaglutide, you get subcutaneous semaglutide. A lira duraglutide already ache for diabetes management. So this is once weekly, this is once weekly, this is daily, this is subcutaneous, and oral is daily. The oral semaglutide problem holo, the bioavailability is only 1%. So it has to be taken in empty stomach with 120 ml of water, not more, not less, and half glass jol bola hoy, and half an hour কিচ্ছু খাওয়া যাবে না, জলও খাওয়া যাবে না, একটু স্ট্রিনজেন্ট আছে, কারণ 1% only bioavailability, একটু এদিক ওদিক হলে অ্যাবজর্পশন প্রবলেম হয়ে যায়। So personally, I have shifted most of my patients now to subcutaneous semaglutide. এই নশিয়ার ব্যাপারটার জন্যে we start off with the lowest dose. Every week you give that for 4 weeks, then you increase the dose, 4 weeks, you increase the dose, 4 weeks till you reach the maximum dose. Now, GLP-1 plus GIP, কি আছে? Tirzepatide, which is Mounjaro. So if you see here for obesity with semaglutide and orforglipron is also GLP-1, you get about 17% weight loss in the maximum dose. In diabetes, patients always lose less weight as compared to non-diabetic. So there you get about 10%. And if you add GLP-1 plus GIP, which is Mounjaro, you get 22% weight loss, almost achieving close to bariatric surgery results. Now, আমি গ্লুকাগন অ্যাড করেছি, তাহলে এখন তিনটে, এই মঞ্জারো আছে বাজারে, semaglutide আছে বাজারে, নেই আসবে শিগগিরই হলো গিয়ে ট্রিপল জিআইপি GLP-1 প্লাস গ্লুকাগন, তার নাম কি? রিটারট্রুটাইড। মাল্টিপল ট্রায়ালস হয়ে গেছে, ইট উইল কাম ইন দ্য নেক্সট 2 to 3 years. আরেকটা আছে GLP-1 প্লাস গ্লুকাগন, এটার নাম হলো গিয়ে সার্ভোডুটাইড, এটাও আসবে another 2 or 3 years time. And with them you can see রিটারট্রুটাইড, the weight loss is close to 25% weight loss in patients with obesity. Cagrisima arekta royeche, but I will preserve that for some other day. So the last slide, and it's perhaps very important here to emphasize, any treatment you use to tackle obesity will cause some degree of muscle loss. Any, whether it's diet only or diet exercise or any drug, it will cause some amount of muscle loss. So I always tell my patients, please do isometric exercise every day. That's the only modality which will preserve your muscle. Muscle mass kome gele sugar bede jay, because once you eat, 60% of the blood sugar is taken up by the muscles, postprandial state. So if your muscle mass reduces, blood sugar goes up. So you have to preserve your muscle mass. Simple আমি বলি যে বিবেকানন্দর কথা ভাবুন, কেন বিবেকানন্দ বলে এরকম করে বসুন, যখনই দাঁড়াবেন, কখনো আমরা কী করে দাঁড়াই, চেয়ারের হ্যান্ডেলে এমনি করে দাঁড়ালাম না, বিবেকানন্দ যখনই দাঁড়াবেন বিবেকানন্দ, অ্যাটলিস্ট ইউ স্ট্যান্ড আপ অ্যাটলিস্ট 20-25 টাইমস এ ডে, আপনার পায়ের মাসেলে হয়ে গেল। আর যখনই দাঁড়িয়ে আছেন স্থির লিফটের মধ্যে, ইউ ডু দিস, দ্যাট উইল বি আইসোমেট্রিক এক্সারসাইজ অফ ইয়ার কাফ মাসেলস। ফর দি আপার আর্মস, you can just lift up a bottle of water, 1 liter, and you can just do this while you're sitting in the chamber waiting for your next patient to come. Upper limb, lower limb, without taking time out from your busy schedule. So that's isometric exercise, which is crucial whenever you prescribe anti-obesity medications. So with that, I end. Thank you very much.
Thank you, Dr. Gangopadhyay. I have heard him earlier. He's an excellent speaker, and I think everybody is very got enriched with the deliberation. Now, one question is allowed. One question, if there is any. So, few of us should wait for 2 to 3 years because some drugs will come.
If there is no question, I have a question,
Yes,
sir.
please.
So when we were discussing the drugs, semaglutide, liraglutide, is there any cutoff after which you reduce the dose, or do we maintain that highest dose lifelong?
So that's why you need to find out the indication why you're using it. So that's why important which particular disease the patient is having related to obesity. So if you have achieved that target, so then we can say I won't go any further. Or if you have exceeded that, I might de-escalate to back to that. So that's why it's important to identify it.
But you continue.
But you continue. So patient এটা costly medicine আমরা কি করব এতদিন চালানো যাবে না. So there has been trial with Monjaro. Patients took the drug for 6 months. তারপরে বন্ধ করে দেওয়া হলো. So এই 6 months-এ about 17% weight loss হলো. বন্ধ করার 1 বছর পরে 9 কিলো 8 কিলো আবার গেইন করলো, কিন্তু স্টার্টিংয়ের থেকে তখনও 9 কিলো কম আছে। So what I tell the patients, suppose it is for osteoarthritis I've given. So if you lose 16 kilograms, your arthritis pain really improves. Then you exercise more and you keep trying your lifestyle changes to keep the weight down if you are stopping the drug. But 1 বছর পরে about 50% regain হয়ে যায়।
Thank you.
Okay.
We will invite the next speaker, Dr. Kaustubh Chakraborty.
So juxtaposed between the endocrine perspective and the surgical management is my physiatric management of obesity. So this portion has been discussed. What I'll add is that previously it was thought that obesity is a lifestyle disease affecting only Western or developed nations. WHO now says except the Southeast Asian region, obesity is the principal malnutrition affecting all other countries of the world. So the number of people who are overweight and obese, they outnumber the undernourished population of their countries, be it developing or be it developed. So what are the physiatric challenges? We know what diseases are there. A person gets the motivation to lose weight only after a secondary complication like pain or immobility has occurred, maybe due to arthritis, maybe due to something else. But then that pain or immobility will be the one preventing him from effectively carrying out exercises. The result is he gains weight more. The condition that has developed, arthritis or something, that worsens. So there's a vicious cycle. A bedridden patient with obesity is a nursing challenge in turning the patient, in maintaining the turned position, because the center of gravity has shifted. So the patient will have a tendency to roll back. This will give rise to pressure injuries and some other things such as postural contractures. The muscle mass of the body may stay the same, the adipose tissue mass may increase, so the muscle power is now inadequate to move the body, giving again rise to immobility. Obesity is also associated with heart failure and pulmonary hypertension, which will restrict the amount of activity we can prescribe for a patient. So this will lead to a longer hospital stay because our target goals will be reached much later. This will increase the risk of other things such as hospital-acquired infections if the patient stays longer. It's also associated with obstructive sleep apnea. Now, OSA, besides potentiating the heart failure and pulmonary hypertension, will also cause daytime somnolence. So the patient is losing quality time during the day when the therapist might work on him to mobilize him. So his participation is automatically diminishing. Lastly, obesity may cause potentiate DVT. Now, when one limb is affected to DVT, unless and until that therapeutic level of anticoagulation is reached, we do not move that limb. So again, we are at a disadvantage regarding mobilization. So management has been caused, but I'll put it where Dr. Gangopadhyay has very lucidly put it, but let's do the math. Now from 90 kilos, I want to reduce to 85 to 81 kilos. 1 gram of fat will give me 9 kilocalories of energy. So if I want to lose half a kilo of fat per week, I must deprive the patient of 4,500 kilocalories per week. So that is 600 to 700 kilocalories per day. By diet alone, this is quite impossible to maintain. Therein lies the role of exercises, medications and surgery when the maths gets impossible. What if my target weight is the starting weight is 136 kilos. I want to reduce it to 80. So it will take more than 2 years. To stick to this diet and exercise program, we often require a behavioral intervention in form of psychotherapy, such as motivational interviewing, cognitive behavioral therapy and interpersonal psychotherapy. And medicines have been discussed. Surgery shall be discussed by the next speaker. The guidelines are to lose weight, at least 200 to 300 minutes of moderate to vigorous physical activity per week should be done. And once we have reached the target, to maintain it, a minimum of 150 to 300 minutes of moderate exercise or half of that of severe exercise to be done. Many a time, this person has been inactive. He has not been exercising regularly. For them, we should start low and go slow. And we should spread out this 200 to 300 minutes throughout the week, ensuring that 48 hours gap is not there between 2 sessions. It should not be 1 day of very vigorous exercise and then 6 days of rest. It cannot be that. To prevent injuries, appropriate clothing, appropriate footwear and proper equipment should be there. And we need to combine the exercises. So we have said moderate to severe intensive exercises. So for the intelligent patient, we give the Borg scale or modified Borg scale, wherein 10 is the maximum perceived effort, 0 means you are at rest. So light exercise would be between 0 to 3, moderate would be 4 to 6, and heavy would be 7 to 10 in the modified Borg scale. But in the average patient who cannot understand this, we'll say a low intensity would be that when you can exercise and talk at the same time, or maybe something like slow walking. If you're able to talk but not have the breath to whistle during exercise, such as in brisk walking, that is moderate intensity. And when you are doing the exercise, you have the capacity of only to talk in phrases, not sentences, then it's a high intensity exercise. HIIE is a variant of high intensity exercise and it has been shown to be beneficial. So the types of exercise, as Dr. Gangopadhyay also said, so one should be there to increase your cardiovascular capacity and pulmonary capacity. So aerobic exercises do have a role in that and they also burn the fat. But resistance exercises would be one to build up the muscles and also compensate for the muscle loss. When neoglucogenesis occurs, it will affect the fat as well as the muscle. So there will be some muscle loss. We want to compensate for that. We need resistive exercises. There might be some joint stiffness. We need a full range of joint, and maybe the patient also has been immobile for the exercises to be done properly. And as I've said, the center of gravity often shifts. The obese patients are at risk of falling. So we should integrate some balancing exercises and a combined strategy. When the patient is exercising, better do all 4 will give us the results. Benefits are also there, and even if the patient has come for dialysis, so this photograph is of a foreign place, but we have this small mini bike in our department, and Amazon it costs less than 2,000 rupees. So during the dialysis 4 hours, they can utilize this time. During a cancer chemo, they can utilize this time for exercises. And this is an example of an exercise program. And I tell my patients that fat will burn in the furnace of muscle. So you increase the size of furnace, more fat will burn. Target the proximal muscle groups which will have more benefit of the arms and legs. Add a few per week, and as you develop the muscle mass, you will get greater and greater reductions. So for arthritis, we try to protect that joint and do the exercise for the others so that as to keep up his cardiovascular conditioning. And in conclusion, I'll say that a mixture of all the treatment modalities are required, and the physiatrist's opinion should be taken, who understands the drugs taken, who understands the comorbidities, and prescribes the right exercise for the patient. Thank you for a patient listening.
Thank you, Dr. Chakraborty. But it is very difficult to tell you that I will start doing exercises from tomorrow. So now it's any question? One question allowed, please. Our next speaker will be Dr. Prosenjit Bhattacharya, my colleague at PLS Hospital, consultant pediatric surgeon, who will discuss on the surgical aspects.
Good evening, everyone. Already the pathophysiology and other aspects of obesity is discussed already by my previous speakers. So I will directly jump into the surgical management. I will be talking about the last part of the obesity scale, that is the morbid obesity, because morbid obesity will never respond to any lifestyle change or medications only. And the problem is that medication is a temporary thing. Its effect will wane off whenever you stop the medication. Number one. Number two is it is costly. If you continue the medication lifelong, it will cost very significantly in the patient's lifestyle. So here comes the role of bariatric surgery, because bariatric surgery is the platform, is the method that will offer the patient a durable and significant reduction not only of the weight but also remission or a significant reduction of all the comorbidities that is associated with the obesity. So it comes from the Greek word baros, which means heavy or weight. Here from there comes the bariatric surgery. So directly I am coming into the indications. What are the indications? So there are two different indications, two different systems of indications. One is ASMBS criteria. It is most widely followed all over the world. Association of American Society of Metabolic and Bariatric Surgeons. So if the BMI is more than 40 and if the BMI is more than 35 with comorbidities, they are considered as the candidates for bariatric surgery. Another criteria is OSI criteria, that is Obesity Surgeons Society of India. So this indication, the criteria, the indication for surgery is a bit tailored to the Indian population. So the Indian populations without diabetes, the BMI more than 37.5 or with comorbidities more than 32.5. And the last part, that is the metabolic syndrome. Here the BMI can be more than 30 or even it can be up to 27.5 to 30 range in some selected patients. Here the metabolic surgery has a role, because bariatric surgery there is a variant of bariatric surgery that is called metabolic surgery. Here surgery is done for the resistant diabetic patients for a permanent cure. So what are the other requirements of OSI? Age should be age should be between 18 to 65 years. There should be failure of the medical therapy, because if the patient is continuing diet, medication, exercise, all sorts of methods to reduce his weight and comorbidities, but they are for at least more than 6 months, but they are failing. Number 3 is evaluation and readiness. All obese patients are not candidates for bariatric surgery. Even not all morbidly obese patients, those patients who are psychologically willing to undergo a bariatric surgery and to follow the post-operative advice lifelong. There should be a nutritional counseling of the patient, that what kind of food he is going to have in his rest of his life. Fizzy drink, alcohol, sweet drinks, fruit juice, they should be completely avoided throughout his life. These are the things you should be counseled about. Now, number 3 is the ability to long-term follow-up. Whether the patient is willing to follow up for a long time for his life. Because bariatric surgery, those patients who lose follow-up, they usually land up with some nutritional deficiencies in the emergency. What are the contraindications? So untreated major psychiatric illness, active substance abuse, severe cardiac risk, uncontrolled endocrine disorders like Cushing's, and pregnancy. They are the absolute contraindications for bariatric surgery. Now, what are the types of bariatric surgeries? This is a format which I have used here, but nowadays a bit changed it is. So, what are the types? One is restrictive procedure, where only the stomach is reduced in capacity, like sleeve gastrectomy. It is the most commonly performed bariatric surgery all over the world. Here also, we have done most of the cases by this sleeve gastrectomy. Another is intragastric balloon. Intragastric balloon is a balloon which is introduced endoscopically to temporarily reduce the stomach capacity for the optimization of patient for a bigger surgery, like the patients who are called super obese, whose BMI is more than 50. So they are planned for a bigger surgery, but for the optimization of the comorbidities, sometimes it is done this intragastric balloon. Another is malabsorptive procedure, where there is the malabsorption has been created surgically to reduce the weight and the comorbidities, like biliopancreatic diversion with or without duodenal switch. Another is combined procedure. Here restrictive as well as the malabsorptive procedure, both is combined, like mini gastric bypass or one anastomotic gastric bypass. This is also very quite commonly done here. And another is Roux-en-Y gastric bypass. Now some newer techniques have come, like single anastomosis duodeno-ileal bypass, duodenojejunal bypass. They are usually done for the super obese patients, like whose BMI is more than 50, 55 or 60. And lastly, the endo sleeve. It is quite promising. It has just been introduced in the India recently. Endo sleeve it is done endoscopically, just like sleeve gastrectomy, where we laparoscopically remove a part of a stomach, longitudinal part of a stomach. It is done in endoscopic way. So the part of the stomach will remain inside the abdomen, but the effective capacity of the stomach pouch will be reduced. Now the mechanism of weight loss. Earlier it was thought that restriction or malabsorption is the main cause of this weight loss. But nowadays there are few evolving theories which have come up. One is this hormonal milieu. Dr. Gangopadhyay has already told you about this hormonal milieu, that is the change in GLP-1 and ghrelin. They are responsible. This change occurs after the bariatric surgery. Change in the glucose absorption after this bypass and these restrictive procedures. The delivery of glucose is decreased in the proximal intestine, and it is increased in the distal intestine, thereby changing the portal system milieu in the small intestine and reducing the weight. Another is change in the immune function. As you all know that obesity is a chronic inflammatory state, and this chronic inflammation is responsible for the liver disease, the high risk of cancer and all other comorbidities. So after bariatric surgery, it has been seen that the immune markers, the inflammatory markers of the blood, that come down to almost normal limit. Change in the bile acid pool. Here the bile acid pool gets increased after the bariatric surgery, and they play a very important role in weight reduction and other reduction of the other comorbidities. And lastly, the change in microbiome. It has been seen that the richness and the versatility of the microbiome, that is changed in the obesity. This Firmicute type of microbiome, that is increased in obesity, and bifidobacter and anaerobic bifidobacter, their levels are reduced, but after the bariatric surgery it is changed, and the anaerobic microbes gets increased, which is responsible for the weight loss. Now this is the impact of weight loss. You can see that the impact of these three most commonly performed surgery, they have on this excess weight loss and the time that takes until the weight loss stabilization. So it is quite significant. The gastric bypass is at least 60 to 85% causes this excess weight loss. Sleeve gastrectomy around 55 to 80%. And this adjustable gastric band, that is another method of bariatric surgery. It is a temporary method because it can be reversible. It has 45 to 55% of the excess weight loss. Now here is the impact on comorbidities. The diabetes, there are several studies. So it has been seen that around 26 to 30% of the, there is a long-term remission in diabetes. In hypertension, around 84% cases there is reduction, and in 45 to 50% cases there is complete remission of diabetes, hypertension. In dyslipidemia, there is 33% reduction in dyslipidemia. There is very improved cardiovascular risk, significant reduction in hormone-related and skin cancer risk. There is around 70-71% reduction in OSA and remission. Around 70% symptom improvement in GERD, around 70-75% improvement in joint pain, renal disorders, obesity-related chronic liver disorders. There is 50% improvement in sexual health, as well as 74% improvement in depression and significant decrease in a binge eating disorder which is associated with this obesity, especially the morbid obesity. So here I have given some widely available animation to just depict what is the method. So this is sleeve gastrectomy. Here we longitudinally divide the stomach and remove the excess part, keeping a 150 to 200 ml pouch inside the abdomen, thereby restricting the amount of intake. This is mini gastric bypass. We cut off the excess stomach and make a 30 ml pouch where this jejunum loop is stitched with the pouch. The length of the limb should be at least 80 to 110 centimeter. This is Roux-en-Y gastric bypass. Here it is divided, the jejunum is divided, a roux limb is anastomosed with the pouch. And this is adjustable gastric banding. Here an inflatable band is inserted and tied around the stomach. And there is a channel through which saline has been given, and the band is inflated and the effective capacity of the stomach pouch is decreased. This is a reversible process because if you want, you can remove the band, then the patient will again go to its previous state. So what are the complications? There are some immediate complications like bleeding, leak, internal herniations. This is quite common in other abdominal surgeries also. And some late complications like intestinal obstruction, weight regain. Now, if the patient, after it has been seen that after 1 year or 2 years, sometimes the patient lost follow-up and started eating in previous manner, then only this pouch gets enlarged and takes the shape and size of the original stomach. Then the weight regain started. So we used to tell the patients to strictly adhere to the follow-up program. So bariatric surgery, it is the durable solution of morbid obesity till date. It has been proven. There is significant improvement and remission of the comorbidities, and it restores the patients in their normal social life. But despite the surgery, we advise the patients to maintain the change in diet and physical activity strictly throughout their life. Thank you.
Thank you, Dr. Bhattacharya. Very interesting talk and very entertaining too. Any question? We will take one question. No? Maybe I would have one question. Okay. So the question is, do you all frequently see relapses after the surgery? How common is that?
No, it's not very common because usually the patients, they usually maintain the follow-up. Okay. The lifelong, they have to maintain this 1200 kilocalorie diet. They can eat anything except the sweet extremely sweet fruit juice or fizzy drinks or cola or alcohol, but they have to maintain that kilocalorie level up to the 1200 kilocalorie throughout his life, and some vitamin and trace element supplements. So usually they maintain throughout their life, most of the patients.
Thank you. We should end this session. We will move on to the next session. But
Yeah.
memento.